Barrow, Garrigus, Chalmers, Anaquenze, Namdari, Gillespie.
And how long for each of us to keep us on time?
About 10.
Great. Perfect.
But
Thanks.
I think we have plenty of time. I mean, I think we got almost 40 minutes of Q&A built in. I'm not too concerned if you go a little over.
All right, 5 o'clock, boys. You guys are ready to begin.
Okay. All right. Welcome, everybody, to this webinar on the ABCs and the 5Ps of TSA and the ASC. I'm Quinn Throckmorton. I'm with the Campbell Clinic in Memphis. I'm joined by just an absolute superstar faculty here to discuss really all the aspects of outpatient shoulder arthroplasty and how you can develop it and apply it in your practice. It's such a great faculty. I want to call them out each individually. Chris Clifto will start. He's from Duke. Ron Navarro is from Kaiser Permanente in LA. Grant Garrigus from Rush. Peter Chalmers from Utah. Oke Anaquenze also from Duke. Serena Namdari from the Rothman Institute in Philly, and then Robert Gillespie is traveling, but will have a recorded presentation for his portion, and he's with University Hospitals in Cleveland. So each one of these guys is a leader in our field and an authority on the subject we're going to be talking about tonight. So it's really an honor to be with them. Chris, I'll turn it over to you. You're going to talk about pathways.
Okay, awesome. Thank you so much, Quinn. And thank you, everyone, for putting on San Diego Shoulder for another year. It's always more fun to be in person, but this is a wonderful other opportunity. So I'm going to be talking about pathway to ASC total shoulder development, and really excited to actually talk about this because this was a large part of the last 5 to 6 years of Dr. Anaquenze and I's practice together. So no relevant disclosures. So how do we know a TSA patient was not a good outpatient shoulder arthroplasty or ASC surgical candidate? Well, anyone who wears a Disney shirt, grumpy is the worst. Those persons were automatically inpatient only. If they come into your clinic wearing sunglasses inside, can't do them in an ASC. If they write extensive extra history in the margins of intake form, probably not the best ASC candidate. If they mark skin with pen to designate localization of pain, if they take notes during the visit, if they have a protective wristband for their metal allergy, or if they have a first name as their first and last name, and of course, anything multiple is bad, multiple cats, multiple rings, multiple allergies. All these patients were automatically excluded for us in the past, but we got a little bit better. So we focused a lot more on optimization, and I'm going to briefly just talk about our overview of our process for creating this pathway. So we do know that shoulder arthroplasty was historically an inpatient procedure, and there have been drivers for outpatient ASC arthroplasties. We are operating on younger, healthy patients. There is a financial burden to the healthcare system to optimize revenue, and this is a good way to do it. And we have improved pain management and patient optimization. So I'm going to focus a little bit more on the latter there. And then it's also a patient preference. A lot of patients want to save money and go home the same day in the ASC. And Quinn's work really set the groundwork for this. This was his awesome NEAR award from 2016 that looked at 30 outpatient, 30 inpatient TSAs, found no difference in readmissions and comparable minor complications. So once we saw this study, we thought, hey, maybe we could do it ourselves. And the truth is, in 2021, we're able to actually move to the ASC because it was moved from the inpatient only list. And when we started really looking at the data out there, we found that there are substantial cost savings, not only to the patient, but for the hospital if we move to the ASC setting. So all this led us to, hey, figure out how we can make it better in our own institution. And it started with actually partnering with Oki and Grant in our own pathway development, where we really start to look at our data. And we had this 2-institution cohort where we looked at all of these comorbidities that you could see on the right. And the beautiful thing about this data set was we had 2 different cohorts. We had, Grant's high-end, totally optimized patients, and Oki and mine, southern fluffy patients. But it was a really good way to understand which patients would be better in the ASCs. And we looked at multiple different questions. What is a good outpatient appropriateness? What's good for 9-day readmissions, discharge to subacute facilities, extended length of stay? And we used all the comorbidities on the right to really start building our own pathway. So if you're going to build your own pathway for an ASC, looking at your own data is a really good way to start. And we looked at multiple studies. Grant's going to go over these in detail, so I'll just kind of gloss over them. But essentially what we came up with was there were 13 variables that for our 2 cohorts were really important, which was surgery duration all the way down to specific medical comorbidities. And we found these 13 were the most important for our at least demographics. So this led us to really focus on our patient optimization, what patients were best for the ASC setting. And there's things that we can fix and there's things that we cannot, innate fixed factors like age, gender, genetics, we really can't modify them and optimize for the ASC setting. But there were ones that we could modify, like alcohol, smoking, and nutrition. And I'm going to talk a little bit about how we did that for our pathway development, how it's really changed our practice and outcomes. We looked at different things that we really tried to fix: anemia, glycemic control, all the way down to mental health disorders, obesity, smoking, things that we really thought that we could change. And we created this thing called the PASS Clinic, and it's called different things in different institutions, but it's essentially a way, how do you optimize patients from not only their comorbidities, but from their nutrition status to have the best outpatient ASC result. And what really drove this was when we looked at our own data, anytime a patient returned to the ER or got specifically admitted after an outpatient shoulder arthroplasty, the average complication costs our healthcare system almost $12,000 per readmission. So we really didn't have much wiggle room to make errors in this process, especially if the healthcare system was going to allow us to continue to do it. One of the things that we came up with is alcohol dependence. This was essentially a non-negotiable thing for our patients. If they had more than 2 drinks a day or we felt that there was any sort of dependence, we would push them into the inpatient setting and actually try and get them to stop drinking at that frequency. And then smoking, patients had to at least have stopped smoking for 4 weeks if we could. We know this substantially improves outcomes, decreases pain scores, and readmissions. So those were 2 modifiable things we started right off the bat. We also start to look at malnutrition from our 2 institutions again, and specifically see how it affected readmission. So again, this was another multi-center study between Rush and Duke. We found that there was a high frequency of malnourished patients if we went back our data, 37% for revisions versus 20% for primaries. And really, if you look at it, these patients who were malnourished had worse outcomes. They had a 13% increase in extended length of stay, 8% increase in discharge to SNFs, but no real 9-day readmissions. But we thought that if we could modify this and make it better, the chances of ASC readmissions and poor results would be less. We also looked at just our literature in general and other people's literature showing that malnourished patients, specifically a BMI less than 18.5, had higher complications over every other BMI group. So we really focused on improving our nutrition status of our patients before the ASC arthroplasties. And so we came up with this nutrition score that all of our ASC arthroplasties went through. They essentially do this journal where if they have a BMI of less than 18.5, if they have unplanned weight loss over 10% in the last month, or they're eating less than what they normally have, or if they have an albumin less than 3.0, they're going to have to go to a nutrition evaluation, and we would delay their surgery until we got them optimized. And the question is there a way that we could improve our nutrition supplementation for these patients on top of these dietary requirements that we're asking them? Well, every patient, no matter what, for us, if they're getting an ambulatory outpatient surgery, gets a protein supplement. The best one that we found, and no conflict here, is Fairlife. But it's any sort of protein supplement we try and get them to take before surgery. And then we would have these specific supplements that we would ask them to take. We'd have them do leucine, which is good for improved muscle endurance and lean body mass, glutamine, which is improved for immunity and decreased antibiotic processes, vitamin C, which is good for increased collagen synthesis and decreased inflammation, and magnesium, which is good for improved muscle synthesis. So we try to get all of our patients to take all these supplements before any outpatient surgery to decrease our complications. And this is something we started doing recently, where every patient 2 to 3 hours gets a 50-gram carb clear liquid drink. This we have found from the literature decreases length of stay, decreases postoperative pain scores, and improves insulin sensitivity. And if you talk to your anesthesiologist, they're usually okay with this. And then we're not doing this, but I thought this would be something new for this webinar to just briefly talk about peptides and culture because it's coming. You can see that RFK has essentially waged a war with the FDA to bring peptides to our patients. And not this is a political thing, but most of your patients, especially the ones who are well educated, will ask you about peptides. So I just thought I'd briefly go over the different types that there are. There's the BP157s, the TB500, the Glow Stack, the Sermorelin, and the GLPs. And just what to understand when your patients ask about this. The BP157, it's improved for, it's good for improved ligament healing, tendon healing, accelerated muscle generation, and it's called part of this thing called the Wolverine stack. There's the TB500, which is again part of the Wolverine stack, which promotes angiogenesis, apoptosis, decreases inflammation. Again, this Wolverine stack here. And then there's the Glow Copper, which is another one that our patients ask and sometimes try and take, which are good for improved wound healing and antimicrobial properties. And then there's a Sermorelin, which is essentially a growth hormone analog, and it decreases body fat, increases muscle mass, and increases energy levels. And then we all know about the risk of this, which are essentially any sort of growth hormone risk, which is acromegaly, cancer, peripheral edema, and type 2 diabetes. And then lastly, the GLP-1s, we know that this increases bone mineral density, lower rate of osteoporosis, and lower risk of fracture. And a lot of these patients come in and ask about this on a routine basis. And frankly, a lot of our patients are starting to use them at this point. So if you're going to start the process for the first time and you haven't done it, the first thing to do is to work in a familiar setting. And you could usually start this process by doing a dry run in your hospital just in case something goes wrong. Start with good patient selection, which are healthy young patients. Organize the team. Use your team that you normally would use as an inpatient in the outpatient setting, the ASC setting, and then just organize the process. For us, one of the things that has been super helpful is patient resources, and we spent a huge amount of time working on handouts, and more handouts. Every single patient gets preoperative handouts, postoperative handouts, and we have a huge buy-in from nurse navigation. When the healthcare system saw how cost-effective that this was to do, they invested a lot of resources, and these nurse navigators help manage our patients pre-op and post-operatively. And then we've had a lot of physician supports from cost savings from implant vendors or whatever to make this process more affordable for everyone. And then we got buy-in from the facility, including anesthesia and PTOT at our ambulatory sites to come in-house and do some counseling with the patients. So huge buy-in from our healthcare system, which has been amazing. So this is our current workflow. Every single patient gets an evaluation from the PASS clinic for optimization nutrition. They have the surgery. In the postoperative recovery area in the ASC, they have a PT evaluation. Then they have a nursing evaluation to make sure that they're ready for discharge, and we keep working with them and optimizing if they're not. They get telephone calls at 1, 3, and 7 days, and it's been a really nice process for us. And we looked at my own data for this, and frankly, it was kind of shocking how bad I was at my readmissions from the ER and inpatient. You can see here, 11.5% readmissions. These were largely medical, but there were some surgical as well. And then when we started doing this optimization process, you can see that goes down to almost 0% in the next year. So if you can follow this pathway and get buy-in from your healthcare system, it has huge effects on your readmissions and outcomes. So in summary, ASC shoulder arthroplasty, the process is just inevitable. The approach should be incremental. Start slow if you're going to do it. Have a really strong, consistent team. Refine the process. And thank you for allowing me to just talk about our pathway at Duke.
Thanks, Chris. Excellent job. You and the Rush group have done some great work this way. So we're going to flip gears and talk about pain control. Ron, you've done a lot of work in this area along with Anshu, so we're looking forward to you sharing your insights.
Yeah, thanks, guys. I'm trying to find my talk so I can kind of make it into a big. All right, you can see it, I think. Great. Quinn and Howard, thank you for putting this together. San Diego Shoulder Institute, wonderful place, and all the other speakers here. Thanks. I'm excited to share some of our thinking on this. I don't have any conflicts. We in Kaiser Permanente, we get the need to move to the ASC. You know, we're in a prepaid system. It's all cost centers. So if we get people to not spend as many nights in beds, heads in beds, it saves the beds for more acute patients. And frankly, in a prepaid system, it sort of saves money, so that money can be placed into other people. So this study we did at some point in the past, we proved that same-day discharge was not inferior to in-house for 90-day readmissions, 90-day ED visits, and one-year mortality. And the patients had more satisfaction. And as Dr. Clifto said earlier, patients really kind of like it when you kind of give them these new protocols and regimens, because they really enjoy the extra attention in many ways. So why do we need better pain control? We need to get pain control right. This was a great study by Matt Saltzman, who was a fellow with Dr. Mattson and team in Washington, that kind of showed pain pumps really, we hurt people. So we've whiffed on this before. So we need to get pain control right. If pain control isn't done well, we've in our own study shown that pain and falls are top reasons for early return to care after primary elective shoulder arthroplasty. So for just those two and many other reasons, we have to get it right. So we kind of started a long time ago with the idea as pain was the fifth vital sign, and the Institute of Medicine put that out there, and there was a lot of extra pain meds that were placed and given to people, and we were probably contributing to the opioid epidemic. I think all of us know patients that we think, wow, did I make that guy an addict or not? So then there was this idea to walk away from opioids themselves, and so newer thoughts emerged on pain control and the idea of multimodal strategies, and other external factors kind of made us think more about how to manage pain in all settings, especially the outpatient settings. And so in California, there was something that came about in many states the same, where you have to check in and let people know kind of what kind of pain meds you're giving as well. The COVID-19 pandemic made outpatient cases mandatory, and there was no more parenteral. So we had to rethink how we did pain control. So interscaling nerve blocks, a lot of this you all know. We did our own study to look at this, and it's a major benefit. And we were able to kind of decrease the time in the hospital space, just in the recovery room itself. But then we were able to see that it could help, and others did great work on this. This is the NYU group. David Ding's now a orthopedist in the Kaiser system, but when he was a resident, I think he did this study, and they saw that with interscaling nerve block or regional anesthesia, they had lower in-hospital complications and readmission rates, and decreased odds of a hospital readmission as compared to general anesthesia. And our friends, Dr. Clifto and Anna Quenze and others in their system looked at both liposomal bupivacaine and non-liposomal, and they both had great benefit, and there was no difference in ED visits or readmits. But all these studies are kind of looking at the idea of interscaling blocks and how they're so beneficial. I did mention multimodal pain control earlier, and Dr. Namdari, who's one of our speakers today, his group looked at this at Rothman, and they described a multimodal approach, and they called it TLC, tender loving care. And that approach, as compared with the idea of pain pump, a traditional kind of idea of a patient-controlled anesthetic pain pump. The TLC method with multimodal had better scores in pain control. They did use a little bit more narcotic and a millimeter morphine equivalents in the first 24 hours, but the patients were much more satisfied, and that's part of the deal. We want patient satisfaction and to get keep our patients happy and under pain control. Ortho Carolina, which has done a lot of work on this, especially Nadi Hamid and his team, they looked at the idea of outpatient shoulder arthroplasty with multimodal, and they saw that they had successful outpatient shoulder arthroplasty with multimodal and no interscaling nerve block. They had less 90-day complications, similar ED and UC visits as compared with other regimens, and so that was really a kind of a great finding and kind of led us forward. That same study did really outline one of the first multimodal frameworks. If some of the others of you have presented before that, I'm sorry if I dissed you. But you see in this medication period, pre-op, intra-op, and post-op, as well as home, they did have Percocet and gabapentin. It's interesting that later on they've kind of come into thinking about opioid reduction and almost no opioids. So we did look at the idea for risk factors after post-operative opioid use, and we saw that 1 year post-op use was high before we performed a systematic reduction. And then we had a later paper that showed that once we did a systematic reduction, we switched our electronic medical record to have a standardized approach to the prescriptions and really a much lower amount of opioid, as well as the state monitoring that I described earlier and surgeon advocacy. That was like mainly people who were kind of suits and also orthopedic surgeons who had to tell people how to do things and kind of monitor them. And in our system, we do unblinded, tracked and trended use, and people see how much they're giving, and then they kind of are somewhat shamed into kind of getting along with the program. And so we were able to show that we had improvement in use of opioids and a decrease and reduction. So this is the narcotic-free regimen that I was telling you about, and that same Ortho Carolina group and others had looked at this, and they looked at a multimodal opioid free pain management pathway. It was safe and effective, superior pain relief versus traditional opioid-containing pathways at 12 hours, 24 hours, and 2 weeks post-operatively. Really great study. And you see in their regimen, in the post-op and discharge periods, there's no narcotics. So it's really exciting, and some of the others of us are trying this. I think it's a long way to go to describe this to a patient and make them think that after a total shoulder, they're not going to get any narcotics, but it's been done, and I hope more of us go in this direction. This is recent literature on ASC shoulder arthroplasty and pain control, and in it there's interesting, a lot of the regimens look similar, and I'm just showing you these papers so that you can read on for yourself, but this was our Detroit friends that put this together. And I will tell you that in our own system, we're looking at changes in opioid prescription by race and ethnicity after shoulder arthroplasty, and we're looking at overdose risk with the combinations of opioids and gabapentinoids. Those two papers will be out soon, and they're going to help further describe kind of some of these nuanced issues with opioids and non-opioids in post-op pain control. What about perioperative behavioral modification? This is Ragnar Lothbrok, or at least the actor who played him. And you know what the Dutch surgeons say when patients say, am I going to have pain? They say surgery hurts. They just tell the patients, like, the surgery hurts. But this is really far from pain as the fifth vital sign in the Institute of Medicine back in the day that I showed to you earlier. But I think the general approach here is we have to gird our patients to prep them for what is to come. We can't tell them that it's not going to hurt at all, and because I think that was the pain as the fifth vital sign approach. keep patients out of pain completely, and that's probably not the right approach. There are apps like Curable, Kaya Health, and Happify that institute a bit of cognitive behavioral therapy to keep people like ready for pain and understand. Relieve RX is another one, and even things like mindfulness and yoga to help prep patients for the post-operative regimen and how they will feel things and what they will respond to and when it's appropriate to take on narcotics and how a little pain is actually appropriate. I just say to people, if you like had a brother and they punched you, you're probably going to do better with your total shoulder than if you've never felt pain in your life. If you've lived that life, I don't know, it's going to be a little bit harder. And so in our system, we've talked about value-based care, and we've looked at things like the volumes of patients and where they are. And we have a lot of shoulder patients that come in with their complaints, and we do a lot of shoulder operations. This shows kind of the volumes of the patients. And so we've built out systems that kind of focus on perioperative virtual monitoring, asynchronous texts and hot links that talk through the pain issues in the postoperative period. And these patient touch points and pain control reminders are really helpful for our patients. And then we allow patients to connect with patient care coordination nurses. And in this way, we get patients away from the ED to the clinic if they're having pain issues, so that we can better monitor them. I'd rather talk to the patient myself, or my PA talk to the patient in the postoperative period, than an unknowing, guessing emergency medicine physician who's not dealing with this as much. And so I think that's the way we can manage through this. There's other options like vitamin C. It presents complex regional pain syndrome, and just a little vitamin C every day in the post-op days, you can really decrease the amount of pain that the patient's feeling. So it's interesting that Chris brought it up in the peri-op nutritional benefit period. In the post-op period, it helps too. The future is now. Cold therapy is old, but cryoneurolysis and things like that are new. Some of this you've heard before. TENS unit, peripheral nerve stimulation, cannabinoids, the byproducts of weed can help. Creams have this in it. Duloxetine or Cymbalta, with its serotonin norepinephrine inhibition of reuptake, can help reduce opioid requirements post-op. So there's lots of combos. In us, how are we doing? We're doing over 85% of our patients are going home the same day, up to 90% by the end of 2025. I don't have that data point, but you see midway through the year, it was we were doing about 86%. And we also do have balancing measures to see if they're staying home. We chose return rate, so returns to urgent care, returns to the ED, and readmissions. And not all of them, like Dr. Clifto said, are associated with the surgery, but some of them are. So we monitor ourselves in this way to have a balancing measure to see if sending a person home the same day is reflected in good care and they're happy there, or they're bouncing back. So this is our balancing measure. So in conclusion, pain control is key to the Surgery Center shoulder arthroplasty success. Physical therapy and motion are important. I didn't mention those. I didn't mention creams per se, which are also helpful. Interscaling nerve block, multimodal, opioid reduction, and pain-free regimens are emerging. Behavioral modification helps. Systems innovations guide good pain control. Vitamin C is cheap and easy. There are other new ideas emerging. I think you have to monitor your interventions. Good luck, and thank you all for this time with you tonight.
Thanks, Ron. That's excellent. It's a very California presentation with cannabinoids and cognitive behavioral therapy and such. I'm going to use that on my North Mississippi country folks, so it'll be good.
Yeah, you got it.
All right, we'll move on. Grant Garragoose is up next. He's going to talk about patient selections and predictions.
Perfect. Let me just get this up here. Can everybody see my screen?
Yes.
Perfect.
Yes.
All right. Excellent. Well, listen, I'll get started. This has been a great session. It's an honor to be here, and excited for this encapsulation of San Diego Shoulder Course. And we've heard some great talks so far. This is going to sort of go through a few of the things that we've seen, but in a different way. So patient selection and predictors, that's some of the P's that we talked about. Disclosures, the big one here is that I am a small part ownership in ASC. So we'll talk about some of the kind of winners and losers in this and how that might play into it. And there's some modeling software in here. A lot of people involved in this. Many of them on this call. Chris Clifto, OK Anakwenze, Daniel Goltz gets a lot of credit for this. Thorsten Seiler from the Duke side, et cetera. Like you can see, it's been really a nice way to work with my Duke colleagues, and excited to kind of take some of the stuff that Chris showed and piggyback on that a little further. So this is not stuff from yesterday, but relatively recent history. So 2021, they took the total shoulder off of the inpatient only list, okay? And right at the same time, they put it into the bundle. So unfortunately, if you're in the bundle, the only ones that would go into the bundle are the inpatients, and those turn out to be the bundle busters. So this was really not a good thing for people if you were in that bundle, which is beyond the scope of this. 2022, after feedback from relevant stakeholders, I don't know. Everybody's got a different angle on this. It does seem that the stakeholders might have been lobbyists holding actual stakes and having dinners with the CMS folks. But again, depending on your perspective, maybe it's good to have this on the inpatient only list. Maybe it's not. And we'll talk about that here. But basically, they reversed this and they said, all right, we're going to put it back, except these one code, and one of them is the 23472. They announced that those would be phased out, and then effective January 1st, 2024, basically they put this off. They allow this 23472 total shoulder arthroplasty as well as hemiarthroplasty to be done in Medicare patients at ASC. So it kind of whipsawed from inpatient to off the outpatient, maybe back on the inpatient, and then now allowed to be using the ASCs just in the last 5 years. So is this good news or bad news? I mean, it really depends on who you are, right? So if you own a surgery center, this is good news because the facility fee is reasonable. There's some margin. You can do Medicare shoulders in a surgery center, and it seems to be cost effective. If you are a patient, well, we'll talk about that. That's really going to be the thrust of this talk here. What about taxpayers? It's good news. It's cheaper for CMS to do it this way, much cheaper to have the surgery care in an ASC setting versus in a hospital where you have all the bells and whistles that you don't need for the typical total shoulder and healthy patient. What about for hospitals? Well, it's kind of a plus minus, right? You're going to lose some of these cases that used to be, drivers of their bottom line, but to kind of throw them a bone, the government did increase the DRG, what they get paid for those that do end up being inpatient. So I think that makes sense, kind of understanding the ones that stay in the hospital probably going to be the sicker patients. It makes sense to pay the hospital a little more for those. What about implant companies? Not good for them, right? This is downward price pressure on the implants. Surgery centers are very, very, very cost conscious. So when it comes to the implant companies, this is going to add to their already pretty robust price pressures. And what about the bundle? I already mentioned, like basically you're taking all the ones that could have made you money in the bundle but the bundle's getting phased out anyway. So that's kind of beyond the scope of this. All right. So how do we navigate the changing policies? And this is something that Daniel Goltz was talking about. So basically, he was talking about the outpatient shoulder arthroplasty, the surgeon as a general manager. You see Billy Bean there from that Moneyball, the great book where you take baseball analytics, you pick the right player, how are they going to fit in the right situation? It's the same thing, right? Surgeons need to operate on the right patient at the right time in the right setting. I think it's really important. So a lot of complex history here. There's a bunch of different studies. I'm going to skip the one that kind of Chris touched on and go over the other two, but there's, as he alluded to, a number of papers, again, with my colleagues here on this call, and you can check it out on Thorsten's website there. So outpatient total shoulder, a lot of literature on this. We just saw some of the great work from the Kaiser Group. The key takeaways is if you have a big registry like Ron and the Kaiser Group have, it shows that outpatient shoulder arthroplasty, they do not have higher rates of readmission, complications, infections, ED visits, or one-year mortality. They do well. Institutional cohorts, so again, smaller levels of patients, but still some of these are fairly large, shows that the complication rates are the same or maybe even lower. So the key thing here, there's a huge selection bias, right? So all those were very cherry-picked patients being taken outpatient. But that's the point, right? You do want to cherry pick. You want the patient to go to the appropriate thing. If they're super healthy, yeah, cherry pick them, put them in the right hospital, in the right surgery setting. in a surgery center where they don't need all that extra, they don't need access to the ICU, 2 doors down, et cetera. All right. So I'll skip this one here because Chris went over this, and I'll go to this one here. So I think the key thing here, the complications win. So who's at risk for 90-day readmission postoperatively? So this was a model that was built, again, with that Duke Rush Shoulder Consortium. And the bottom line is readmissions are expensive, right? So you really want to avoid these. So whether or not you're in the bundle, it's $13K, even just like they hit the door of the ER, you're already looking, in the 5 figures for sure. So this readmissions are expensive. So you really want to avoid those. Marital status is a really big one. So, that goes to the social structure and like who's with these people, how safe do they feel at home? And, a lot of people, even in a big urban city like I am in now, don't know their neighbors that well or don't want to be a burden to them. Or maybe they're not plugged into different, social structures like church or community settings or social clubs, et cetera. So, this is kind of a societal issue that goes well beyond orthopedics, that people aren't as plugged into their neighbors. But the bottom line is if you are married, that is helpful because you have someone in your home that can presumably help take care of you. Alcohol dependence. Again, that goes to, are these people able to take care of themselves? An alcoholic, they're already struggling, and then surgery is going to push them over the edge. Different psychosocial issues like depression, et cetera. Interestingly, surgery, we had a higher complication rate with reverse versus anatomic. And if really, we do reverses all the time. Well, I mean, this is clear from the Australian registry. If you look early on, the complication rate for reverse total shoulder is higher than anatomic in the early time points, period. Multiple registries have shown this. So you can debate about long-term, what's the better implant, et cetera, and that's beyond the scope of this. But certainly early on, reverse is going to be high. And probably, again, part of that is the comorbidities, the patient selection, who we're doing it for, what indications we're doing it for. But it might also be things like, instability and stuff that's going to typically cause a readmission. All right, what about going to a facility afterwards? So do my patients need to go to a SNF or rehab? This is something that's important to predict. Like, obviously, those people cannot go to a surgery center. So I want to show you this. This is now over 10 years old, but this is a Wall Street Journal study where they looked at basically if you think going to a SNF or acute rehab is necessary, I want to show you these charts. So when you're in acute rehab or SNF, you get paid by the government per day. So they get a per diem, day 1, day 2, up to day 20. And then on day 21, they get a lump sum payment for all the remainder of the time they're in that facility. Okay? So that's how it works. And then what's maybe not surprising, but kind of galling, is if you look at center after center after center after center, what they do is they get the lump sum payment and then they kick them out the door. All right? So they hold the patient, they get that 21-day fee, they've maximized their profit, and then the patient's gone. So you could argue if that's ethical or not. I think it's unethical. But I think what it really shows is probably it's not important that they stay each and every one of those days if it's mostly driven by when the check clears from the federal government. All right. The next thing to know is when we look at SNF and rehab, we know it is the primary driver of excess cost in hip and knee arthroplasty. So there's a number of this is, again, from the bundling research, but JAMA, New England Journal of Medicine, obviously pretty big impact journals. They show that the only people that were able to save money in the bundle did it by decreasing the use of SNF and rehab. So when your surgery centers come to you or your hospitals come to you, say, hey, we got to align on implant costs and we got to use the same, cement and we got to do X, Y, Z. Yeah, all that's good. That's fine. But what really drives the increased cost is increased use of SNF and rehab. And most importantly, when they decreased the use of SNF and acute rehab, they did not have increased complications, readmissions, or ED visits. So again, I value what our colleagues at skilled nursing facilities and rehab centers do, but for shoulder arthroplasty, it just doesn't seem to be necessary for the vast majority of patients. All right, so again, this is kind of the model here. This is kind of interesting. So marriage was important, whether they were married or not, as I said. Also important whether the married partner was female or male. So if a male patient had surgery, then and they were married, they did well if they were married to a female partner. if a female patient had surgery and they were married to a male partner, having the husband at home was similar odds ratio to having no one to help them, which really is not good for our sex and how much we contribute to the marriage. But basically having a husband helping you is like having nobody at all, according to this data pretty clearly. All right. So we'll skip through this, but basically the awesome team at Duke was able to come up with this great model. You could put these variables in. And again, I'll show the website one more time. Very predictive of who's going to need that. So these are the patients you definitely want to avoid in a surgery center. And certainly you're going to want to think about this in terms of bundles and your inpatient stuff as well. But these are the people you absolutely want to avoid in a surgery center. And it has a lot to do with, again, social structure, et cetera. So I think I think the key thing here is there's no clinical decision tool that can completely substitute. We have these models, they're cool, but you really need to, holistically evaluate the patient. If you look at them and they've got, and they're having a hard time understanding the instructions and the risk benefits that you're describing in surgery, how are they going to navigate a post-op, home by themselves? I think the next thing is these models are helpful to identify at-risk patients, get them to the appropriate place, set patient expectations. Also important for reliability, right? It's going to protect your decision-making. Why do you send them here versus there? And I think it helps us push back against insurance companies, right? What's important, what's not, right? We need to be able to have the data. The stuff that's not important, yeah, maybe they shouldn't pay for it. But the stuff that is important, we need to make sure that we advocate for our patients to get those type of things. So again, check out this website. At the end of the day, you need to be the best surgeon, citizen, and doctor. You need to minimize your complications. Some of these models I skipped over quickly, but surgery time, blood loss, that's in your hands as the surgeon, right? Are you an efficient surgeon, right? If you got a bloody field there, yeah, maybe you shouldn't be doing these in outpatient. But if you're able to do it with minimal blood loss, safe, good technique. So some of it, we need to look at the patient, but we also need to look at ourselves. So I also want to give a quick plug for our course in Las Vegas coming up at the end of October. But thank you all for the opportunity. Feel free to check out this. And thanks for all my colleagues at Duke for letting me participate in this research.
Thank you, Grant. Excellent work, as we've talked about. Quick note for anybody attending online, we do have a Q&A box. It's currently empty, and I'm keeping an eye on it. So if you have any questions, please feel free to put them in there, and I'll have a look at them. And we have pretty robust time for Q&A at the end of the session. So I'm going to turn it over to Pete Chalmers, who's going to talk about outcomes and satisfaction.
Well, thank you, Quinn. It's a huge honor to be here. I'm missing the in-person San Diego Shoulder Institute this year. It was just a phenomenal meeting. I'm so glad we have this, at least this going on with it. Huge honor to be part of it. Honestly, great talk so far. Grant, you and Chris Clifton, what an amazing amount of work you guys have done. So honor for me to be here following you and Ron Navarro. I'm going to talk a little bit more on the outcomes and satisfaction piece. These are my disclosures, none of which are particularly relevant to this. I think one thing we should acknowledge is that if you compare inpatient and outpatient, the patient experience differs dramatically. The parking, navigating the facility, and check-in experience is much better in the outpatient facility. And the hospital is an anxiety-provoking place. The hospital is a scary place for patients. The phrase for this is nosocomophobia. This is Richard Nixon, who said, if I go to the hospital, I'll never come out alive. He said he never wanted to go to the hospital. This is a picture of a building I drove by with my mother-in-law. And she pointed to it and she said to me, people go there to die. And that's how patients feel about the hospital. So when you do your shoulder placements there, I think patients feel really scared. I think when we think about what the patients care about, they care about how are you as a surgeon communicating with them? They care, do you care as a surgeon about them? How easy was it to schedule? How comfortable am I? How anxious do I feel? How's my pain going to be managed? And you heard a lot from Ron about how to optimize that. How accessible are you as a provider? And then I think the patients care a lot about achieving their goal and having the procedure. And notably absent from this list is the things that we have at the hospital, the blood bank, the ICU, ECMO, robots, lasers, augmented reality. The hospital is not on this list of what patients care about. So what do patients really care about? And this is this great study. And if you are a shoulder surgeon and you haven't read this, I think you should read it because it's a great study that was done. It's published a long time ago. And basically what they did in this study is they provided patients coming to a shoulder surgeon with an open-ended survey of what are you here for? Why? What are your expectations for the outcome of your treatment? And then they grouped their responses. So this is open-ended. This is not like a multiple choice. They asked the patients, just tell us what you're here for. Again, then they grouped them. And these are the things that patients wanted. And the thing that's interesting about this is you can take these responses and you can actually pretty easily map them out onto the ASCS score. So patients want pain relief. So we need to get a VAS pain score. I think if you're measuring your outcome, that's got to be part of it. Patients want better sleep. So we got to measure that. Patients want improved range of motion and strength. Patients want improved ability to care for themselves with their self-hygiene and their activities of daily living. They want to return to the sports and activities that they were doing before. And then there's this desire for the shoulder to return to the way that it was. And for that, I typically would recommend this subjective shoulder value or a SANE score. It's kind of this open-ended, if a shoulder was, normal shoulder is 100, what is yours? And then the final thing the patients sometimes will ask for is stability. So I typically will ask for patients for whom we've performed a surgery for recurrent instability, have you had recurrent dislocations since your surgery? So for me, I will try and take these things that are grouped that the patients responded and map them out onto my outcome scores. And then if I can map all those out, I think that you have a good outcome score because you're measuring the things that the patients are expecting to achieve. And to me, that it has to be that simple. You have to match out what are the patient's expectations and then how do we measure that with our scores. So again, these are the things that I'll measure: the SSV or SANE score, the VAS, the SCS score. I think those three outcome scores give you everything the patients expect. I think it's nice to collect a satisfaction. And then I think if you're going to do a surgery, you want to know, did I have to do another surgery? And then was there a redislocation? To me, this is 14 to 15 questions, and it can be collected in usually 3 minutes. So I think for outcomes collection, this doesn't take long, and it's not complicated. It's not a lot of burden. If you're collecting like 17 different outcome measures, I would suggest to you that you're really burdening your patients to collect information that may actually not be useful. So there's even an argument to say you don't even need the ACS. So this is a study that Keith Baumgartner published that I think it's really influenced the way that I think about it. And what he showed is that if you look at the ACS score and the SSV score, they are highly correlated. And the inclusion of the SSV does overcome a little bit of ceiling effect you see with the SES. And generally, these things are not responsive to instability symptoms. And the SES is not adaptive. So those are some problems with the SES. But there's some argument to say that the SSV may be most of what you need, and that one single question may be enough to gather a lot of information. And since I read this study, I've actually looked often at my patients' own scores, and it's remarkable how often the patient fills out, the 12 questions of the SES score, and it computes a number, and the number equates to their rough estimate of, I think the shoulder is about a 40. So that's because the SES score is a good functioning score, but it also suggests that maybe the SSV is good enough. So if you're going to do the very, very bare minimum, I would suggest the SSV is the very bare minimum. So how do you actually collect this from your patients? And there's a lot of different ways of collecting it. And these have different pluses and minuses. If you're in a system that already has a specific program, you may be using that. How much does it cost? Generally, if you're not doing this, it is somewhat costly. So in 2020, I got this quote from one company. They told me it would cost about $8,000 to set up, and that the annual upkeep was going to be $17,000. So this is pretty costly, and it's hard for you to do as an individual physician. And that's, again, if you're going to use one of these programs to collect it for you. You may say, well, maybe I'll just collect satisfaction scores. And I would discourage people from relying on Press Ganey's. Patient satisfaction is kind of fool's gold. And part of the reason why is because of what we led with, that the patient's satisfaction in their experience is governed by so many other factors. There's so many things about the way in which the patient experiences their care that may not have to do perfectly with your portion of their care. Now, I think that you should work to improve all of them, but that's one reason you may not want to use this as your sole guide. So this is my personal perspective. I am doing something that is not complicated, and I learned this from Rick Madsen. He really inspired me with the talk he gave at the SES meeting about a decade ago. Basically, I have an Excel spreadsheet. So again, it's not technically complicated. It doesn't cost me anything. I will record preoperatively, some demographics on the patient and then their pre-op scores. And so like every day I do a surgery, I make sure I have pre-op scores. If I don't, then I'll collect them from the patient in pre-op. And then at 2 years, I call people. If they don't respond, I send them a text message and an email through our system. And I'll collect what was the data follow-up, what were their scores, and then the things I mentioned previously. Now, the thing that's nice about this is, so today, for instance, in clinic, I have a patient come back. She wants to do her right shoulder. We did her left shoulder 3 years ago. I called her 2 years. We texted her. She emailed. She didn't respond. She shows up now to the other side. I collect the outcomes today so that we still get an outcome. And that hopefully gives us the most complete data set. This has totally changed my life. This very simple thing that any surgeon on this call can do has totally changed my life. And the thing that has changed my life about is all the time I look at the data, I can give patients an on assessment. When I do this procedure, this is the outcome. I can give patients an on assessment. This is my reoperation rate. And I can compare procedures and say, actually, when I do anatomic inverse, this is the change, the difference, the delta between them. So I highly recommend this to anyone listening. It's not hard to do. It just requires it requires a lot of consistency and organization. And that, I think, is where people get tripped up on it. But again, it's not challenging. It doesn't require anything complicated or expensive. So advantages. We standardize time points. I always call people at 2 years. That avoids lead time, length of follow-up bias. For me, my personal data provides patients with realistic expectations and allows for assessment of changes in practice. So I'll change things. For instance, I'll introduce navigation, and then I can look back and be like, how did that change things? Did the outcomes change? Did my operation rates change? And I can honestly say them. And then we sometimes have published those results. I think this is a better way of determining whether you are improving. It allows the identification of trends. So sometimes, for instance, we've published on the failure of one particular anatomic stem, identified that trends by looking at reoperations and say, wait a second, I have too many reoperations with this particular implant. I think it can provide you with solace when complications or poor operations occur or poor outcomes can occur. And this happens to everybody. But if you do an operation that doesn't go the way you want, you can then look back and say, well, what happens on average with this operation? And say, okay, well, this is one patient. Maybe it's the patient I remember, but when I look back in toto, it's 1 out of 100 and the other 99 did great. Certainly allows publication of your own success for practice building. It's focused on the patient. And as I mentioned, it is essentially free. It's time consuming, but it's free. So when I've looked at our outcomes at the U of U, as I mentioned, we collect these through our homegrown system. When I look at our total shoulders, these are outcomes for about 720 of them. And you can see that on average shoulder arthroplasty, it works really well. The vast majority of patients are really improved by it. They have improvements in their ASCS pain scores and the ASCS scores, and they're pretty dramatic. And that's, I think, what we see with shoulder arthroplasty is this works quite well on average with outcomes. Now, if you cherry pick patients, they can look quite different. So when I looked at our data with patients that have really high comorbidity scores, they don't do as well. And certainly that's one selection bias we see in all the literature comparing outpatient and inpatient, is that the sick patients are selected into the inpatient group and that those patients do not do as well. With that being said, when I looked at all comers in my own practice and compared inpatient and outpatient, while there's not a difference in satisfaction rates, on average, the outpatient patients do have higher SSV, lower VAS, and higher ASCS scores. So I think based on this, I can really recommend the outpatient approach. It saves your patients from the fear of the hospital, which again is, as my mother-in-law says, where people go to die. And it gets your patients a consistently good outcome. Thank you.
Great work, Peter. That's got to be a labor of love to be keeping a spreadsheet like that. Well done. Okay, Ana Quenze is next. We're going to talk about finances.
Yeah, thank you so much. And, feel like I have the boring topic, talk about finances, but, this is very important. And this is also more important in today's climate where you, as a physician, unfortunately, have to understand a little bit about business. And I think it ties very nicely into the talks that we've heard. I want to thank the other presenters. These are my good friends for many, many years. I'm always honored to be around them and to talk about something that we all love so much. The agenda here is to talk about the different types of ASCs, talk about the surgeon-owned ASCs and in particular importance of that, the market trends that we're currently seeing in the market as far as the ASC market, and then look at key cost considerations. How do we drive efficiency? How do we look at margins? And then look at the differences between the ASC and the hospital in terms of charges, reimbursement, talk about the private payers, touch on bundle payments and where we're at with that right now, and then finally touch on cost mitigation. So HOPD, Hospital Outpatient Department, this is essentially an ASC that is owned and run by a hospital. The important things here are the facility fees are billed separately and billed in line with the hospital facility fees. So frequently the hospitals have the ability to charge higher facility fees for the same procedures that are done in the ASC. There is some CMS reform that is going on right now, and I think that over the next couple of years, that's going to narrow and potentially be a positive move for the ASCs in comparison to the HOPD. The HOPD are like hospitals. They have high overhead. They have compliance burden. They're subject to hospital level regulations. And then credentialing is done under the hospital umbrella. So at Duke, we have our ASC, and everything is run through the centralized Duke system. And then we think about the financial profile for these. It's high reimbursement rate from payers, that we just talked about, greater staffing costs, longer patient throughput. These are not the most efficient ASCs, but the payer contracts are already in place. You don't have to worry about that, and typically better than the ASCs. The ASCs, lower facility costs. You know, the freestanding ASCs are all about efficiency and all about maximizing margins while providing good care. So the physician controls the operations, streamlined patient throughput, high efficiency, ability to select implant vendors based upon research and what works best in your hands. And importantly, freestanding ASCs do have, as was stated earlier by some of my other speakers, higher patient satisfaction scores. On the flip side, there's certain things you have to consider. If you are part or considering to be part of a freestanding ASC, especially if it's fully physician run, capital investment, equity buy-in, certificate of need laws. So in certain places you are allowed to build your ASCs, and in other places you're not. Insurance credentialing is a big one. It could take 6 to 12 months to get your Medicare credentialing, so you have to start ahead of time. And you have to be more thoughtful about Stark laws, anti-kickback considerations, and other things that can get physicians in trouble, even if they are doing it unintentionally. So you want to think about these things. And it's limited to CMS-approved procedures. So you cannot just do any procedure here, even if they will be safe, unlike the HOPD, where you can almost do what you do in the hospitals at those centers. So there are different types of ASCs. These are three of the big groups: physician, hospital, joint venture ASC, a group of physicians combined with a hospital. The hospital provides the infrastructure, the overhead, the capital, and the surgeons provide the volume. And the different ways they could split it 50-50 or whatever is decided based upon the relationship. I think growing and more commonly now is physician-owned ASCs, full ownership and control by the physician, significant autonomy, highest upside, also highest risk. Again, independent payer contracting, so it's something that you really want to think about. And then finally, physician management company ventures. This is where a management group comes in and says, okay, we are going to help you run the ASC. We're going to help you get your contracts. We're going to help you with your staffing, et cetera. But we're going to own a certain part of the capital table, a certain amount of equity, where the physicians own the rest. So this is sort of a hybrid structure. It's a bit more of a safe structure, but your upside is limited compared to the physician-owned ASCs. Where are we at right now in terms of the ASC market? It continues to be a very promising market that continues to grow significantly year after year. We currently have over 6,300 ASCs and growing at a high growth rate as seen here. I think importantly, it's important to know that orthopedics amounts for 45% of the ASC revenue, the largest segment. That is a really large segment, and frequently is a negotiation and a leverage tool for orthopedic surgeons engaging in the ASCs. Grant just touched on this. The total shoulder arthroplasties were added to the ASC approved list in January of 2024. He's correct. There's been a lot of back and forth over the last 5 years as far as getting the total shoulder arthroplasties into the surgical centers. I think at a high level, I don't want to get too deep into this. I think when you think about the ASC setting in general, from a business standpoint, you have to know certain things, the facility fee, how much the facility earns per procedure, which might be different when you look at an HOPD or a hospital versus a freestanding ASC. Professional fees the same regardless of where you operate. That's how much the surgeon takes home. Everyone knows what inflation is. The value of the dollar sort of getting weaker over time. But it also is important to understand that implant costs rise quicker and higher than the inflation costs. So that puts a cost pressure on the surgical centers in terms of managing costs, because the implant costs are rising more significantly than the interest rate or the inflation. TDABC, I hate that term, but time-based driven activity. Time-driven activity-based costing, I look at that as basically the cost per minute. How much money does it cost per minute of operation? Implant costs, we all know margin analysis, basically revenue minus true cost, and that is your margin. And that's sort of the same for basically almost any business in the world. What are the cost drivers when we look at ASCs? By and large, and has been shown in multiple studies, the implants are the biggest cost drivers. So they're the biggest point of negotiations frequently. Staffing and labor, this is very important, a significant cost driver as well. You need to try to match your staffing to the demand that you're serving and seeing. Facility overhead, rent, lease, equipment, and then anesthesia, meds, et cetera, make up the last. So frequently, you want to think about the implants and the implant costs and supplies when you're thinking about how to maximize your margins and maximize your ability to continue to run a profitable business. When we think about charges, charges, as most of us know, charges don't necessarily reflect the true cost. They don't also reflect what it is that you get paid. But in general, when we look at total shoulders, the ASCs charge about $32,000, where the hospitals or HOPDs also charge about $60,000. For Medicare, they will not get the full $60,000, but for certain commercial contracts, they will be able to draw in that extra revenue, and that's the reason why they charge so high. The ASCs don't really have the ability to charge as freely as the hospitals or HOPDs. But then you look at true costs. So they're both, one is charging 32, one is charging 60, but in terms of true cost, how much does it cost to do the procedure for one versus the other? They're actually not that different. There is a difference. The ASCs are cheaper, about 10% cheaper. But when you look at that at scale, it really does add up. And ultimately, as a physician owner in an ASC, you get a piece of the facility fee. So your personal margin is significantly different than if you're at a hospital. Obviously, when you look at this year, the freestanding ASC, I think volume is very important. Volume is important. We're talking about total shoulders here, but you also want to think about the type of procedures you do. You want to think about if you're going to do revisions or not. We published a study recently showing that outpatient revision shoulder arthroplasties are safe. But you also want to think about it from an economic standpoint. Does it make the most sense? We look at reimbursement. In the ASC setting, I know Serena and Rob are going to touch on this in more depth. Today, you get reimbursed about $14,000, let's say $15,000 in the ASC versus $18,000 in the HOPD. And again, I think there's a lot of lobbying in the CMS to try to make these equivalent so that the hospitals don't get that added benefit. What do you think about from a strategic standpoint? Your lower ASC margins in Medicare, that's the case for the ASCs, but you can build volume, you can be more efficient, and you can use the Medicare as a volume driver and then optimize with your private payers if you're in certain regions to look for margin to continue to run your business. Bundling, we've sort of touched on many times here. Quinn published a nice paper on a bundled payment for total shoulder arthroplasties. And if you look at the unbundled pay structure, we see it costing $33,200. We're in the bundled structure. This is where you align yourself with the payer along certain variables that you agree upon, decreased readmission, reoperation, et cetera. And if you're aligned, you share in the profit and you share in the loss. So it's a good system to know, but it's not for everyone. What are your negotiation tactics? So you have an ASC wherever you are, and you're trying to find ways to move the needle. You can think about volume. Are you a Rothman? Can you pump out thousands and thousands of these cases? That's leverage. That's going to get you better contracts. Your regional rate benchmarking in your specific region. Do you have a certificate of excellence? Do you have things that will draw people to your center and things that the payers are looking for? Implant carve-outs, cost-plus accounts. Certain areas more commonly have this, New Jersey, Florida, Texas. You can look at that as well as an option. And obviously outcomes and efficiency. If you're having complications, if you haven't done what Chris is doing, which is very impressive as far as thinking about your entire pathway, bundling is probably not for you because you might have readmissions, complications, et cetera. You don't want to deal with that. Cost mitigation strategies, in summary here, you want to think about your supply chain. That's one. Purchasing in bulk, your inventory management. You don't want to have things just sitting around. Your vendor negotiations. And then efficiency. Orthopedic surgeons, we all know about the importance of efficiency, not only for patient care, but also in this case to run a profitable business. Pitfalls to watch for. Most favorable notions, you want to be careful with that. That essentially sort of says that, a payer will contract with the best contracting rate for payers that you have given out there. So you have to be careful with the most favorable notions. It limits leverage with other payers. Bundle payment downside we just talked about. Prior auth and denial, this is the bane of our existence, both academic, both private, both ASC, both hospital. But if you're in an ASC, you really need to think about your strategy here. So it's not just random luck. And you really want to think about how you build a strong pre-authorization workflow to try to manage this. And then, the silent PPO repricing, that's basically payers getting access to your contracts without you giving it to them personally, which gives them a negotiation tactic to know that Aetna contracted with you at this rate. So, we want to contract with you at that rate. So you want to be careful about that. Caveats here, we can sort of rush through this. I mean, I think, it's importantly, Medicare, you can't balance bill, meaning, if you're at a loss, it costs you for this particular patient $20,000, you get paid $15,000. You're not allowed to go and charge the patient the extra $5,000, which I don't know is ethical in general. I don't believe so personally. Complex cases may lose more money at the ASC. Rates updates can lag behind inflation, so you kind of have to know the market ahead of time. And then you can use Medicare again to play strategically for volume, not margin. And then payer dependency, basically, if you're more Medicare, Medicaid, you're taking care of the patients that need help. And obviously that's what we're here for. But from a business standpoint, commercial standpoint, it's a bit harder on the math. Generally, if you want to be profitable, you want to maximize your private payers and ideally have a mix. A lot of takeaways here, but in general, the costs are close. The reason why I included this is because I think a lot of us think that it just costs a lot less to do it in ASC. But I think it's a matter of volume. And at volume, it's a big difference. Bundle payments align with incentives that carry downside risk. Understand how to maximize your leverage, your regional benchmarking, your carve-outs. Watch for these silent contract details. Think about your supply chain. Think about your OR efficiency. And then payer mix is really critically important. So as surgeons, I know this is not what we're all thinking about, but I think increasingly we have to start thinking and learning about these little details. Thank you.
Okay, that was excellent. We know why you went and got an MBA. So we are going to transition to a compare and contrast session here. And if you just look around and everybody on the call, we're all in different practices. Some of us are in private or private-emic practice, like Seren and I am. Others are in academic practice. And then and Ron is in a managed care type setting. So we all have different obstacles. We all have different things that could either help or inhibit our transition to outpatient arthroplasty. So we wanted to compare the private setting to the academic setting, and Serena is going to take us through his experience at Rothman.
Great. Can you hear me, Quinn?
Yes.
Okay, great. So thank you, Quinn, for running this. Thanks to San Diego Shoulder for allowing us to do this, as well as Orthobullets. I think the legacy of Jimesh lives on with dedication and years of educating shoulder surgeons around the world. Thank you to the board and John Ticker and JP Warner. So if I can just, okay, so my disclosures are relevant in that I have ownership in my practice, and we'll talk about that in great detail. But as we all know, shoulder arthroplasty has dramatically shifted to the outpatient setting. This is driven by a lot of factors that were discussed by the other speakers, including patient and surgeon preferences, creation of specialized outpatient centers, cost, and of course, removal of total shoulder from the inpatient-only list. Currently, there are 250 physician-owned hospitals approximately, and almost 6,000 overall hospitals in the U.S. 9% of orthopedic surgeons are actively involved with a physician-owned facility. While the growth of physician-owned facilities has been restricted by the Affordable Care Act of 2010, ambulatory surgical centers have boomed, and there's continued to be rampant growth over the next 10 to 20 years. So I think this talk will make a lot more sense if you understand the background of our surgical environment at Rothman. We're a private practice. We provide orthopedic care and educational services to Thomas Jefferson. We also do the same for several other health systems in the region. And importantly, Thomas Jefferson is a partner with us in our 2 orthopedic specialty hospitals and many of our ASCs. For over 10 years, we've taken on this approach of demand matching. This is a term that was used extensively by our former CEO, Mike West, and basically means that we indicate patients for surgery at specific facilities based on their medical and social comorbid conditions in order to optimize outcomes, provide most efficient care, and to reduce costs. This has been attractive for insurers because it means that patients who do not need the resources of an inpatient facility can have their surgery performed at a lower cost facility like an ASC, and feeds our personal goals of providing optimal healthcare at a faster and less costly manner. When it comes from the surgeon standpoint, I think there are really, in private practice, 3 reasons to do outpatient total shoulder. It's a better patient experience, it's an improved surgeon experience, and then there's the financial incentive. As surgeons, I think we all recognize the pains of working in a tertiary care center where the incentives don't always align. The anesthesia team may be slower in order to get through their shift with overall less work. The OR turnover team may have a little less hustle when it gets close to the 2 or 3 p.m. witching hour where the teams turn over, and meanwhile the surgeon is just trying to get the day done. Our anecdotal experience has been borne out in our research. We've shown that an orthopedic specialty hospital results in reduced length of stay, improved operating room efficiency, and a high safety rating. But the elephant in the room is that all the stakeholders in the delivery of care, from the patient to the insurance company to the hospital system, all have a financial incentive, and those incentives don't always align. So the answer is money. What is the question? So from a financial standpoint, it's important to understand that the Medicare payment to the surgeon is the same regardless of where the surgery is performed. I think many of us understand this. The facility payment changes, and these numbers change, but if you look at Medicare payments in ASC, it's approximately $13,000 and about $18,000 in the hospital setting. So we've looked at how much the actual cost is reduced by doing surgery on an outpatient basis at an ambulatory care center, and it's not that different than doing it in a hospital setting. It's almost $1,000 difference. OK showed similar numbers in his talk, but the difference in the facility fee is actually fairly dramatically different at about $5,000. When you look at the surgeon reimbursement, the hospital payments have increased over the years, the surgeon payments have declined. So clearly, we're not doing as good a job as the hospital systems at advocating for our interests when it comes to reimbursement. When you think about the financial incentives, that's what we're talking about here. If you're Jefferson Health System or any health system, your incentive would be that as many total shoulders are done in your tertiary care hospital as possible. Because not only do you get the facility fee at a higher number from Medicare, but you take on 100% of that facility fee. You don't have health partners necessarily. When you think about it, their second best option would be for us to do our surgeries at our specialty hospital, where we still get a hospital facility fee, but they have to share it with us and with a management company. And then the surgery center would be their least favorite place for us to do total shoulders because the facility fee is lower and it has to be shared amongst the other stakeholders. From our standpoint, if you look at a private practice, we would love to do as many of our surgeries as possible at our own specialty hospital because we get the highest facility fee because it's considered a hospital, and we share in that facility fee because we are part owners. The second best place from a financial incentive for us to do it would be at an ambulatory surgical center because, yes, it's a lower reimbursement, but we have ownership in it, and so we share in that fee like OK was talking about. And from a financial perspective, the worst place for us to do our surgeries would be at a tertiary level hospital. So why would you do it? Why would you do outpatient surgery? And I think there are a lot of reasons. There's altruistic reasons. We think about patient satisfaction, lower cost to the health system in general. And then there are personal reasons where it's your satisfaction with a facility that may run more efficiently. You may be trying to stay more competitive in your environment by offering outpatient surgery, home the same day marketing. You get to share in the savings and the earnings potentially depending on what your arrangement is. But we have to be careful what we wish for. The hip and knee colleagues have gone through this experience of transitioning to outpatient, and we're seeing some shifts as well. So if you look at the trends in shoulder and elbow procedure reimbursement for arthroplasty procedures, it's been steadily declining. So this is obviously concerning because we're doing more, we're doing things more efficiently, and by doing more and doing it more efficiently, in some ways, we're making it seem less valuable to those who are reimbursing it. The unintended impact of knee arthroplasty going to outpatient only has been a lot of paperwork. And many of you have probably seen this in your practices with shoulder arthroplasty. I know I have. Insurance denials for inpatient arthroplasty for patients who clearly need it. I've seen patients with walker dependent with no care at home with multiple, cardiac stents, and still it has to be booked as an outpatient and then has to be changed on the back end, which adds significant administrative time. So, I think that in my personal situation currently, I try to do as many patients as I can in our orthopedic specialty hospital. This allows me to discharge patients or keep them the same day. So I think that it's a very safe place to do outpatient arthroplasty. If they need to stay, they stay overnight. And if they're unhealthy and they can't be done at that hospital for reasons of medical comorbidities, then I do them at the tertiary level hospital. I currently do not do outpatient surgery at a standalone ASC because our standalone ASC is not credentialed for it, and so it's not really an option for me right now. If I was to do it, I would think about starting off doing it at an ASC that's honestly geographically closer to the main hospital. Currently, the ASC that I work at is not close enough for my comfort in case somebody needed to be sent over. So I think it's clear from all the talks that you've heard, it's here to stay. The interest in how aggressively you shift your practice to an outpatient practice, I think, is partially determined by your ownership in whether it's an ASC or specialty hospital or if you're a stakeholder in the main tertiary hospital. I do think it's important to have a bailout. So for me, the hospital, I can keep the patients if I need to. The strategies that all the other speakers spoke about how to demand match your patients to the appropriate center are critically important, and you need guidelines for which patients are allowed to be done at an ASC or specialty hospital safely. And then clearly from everything that we've seen, we need advocacy with CMS and private insurers to try to at least quell the decrease in our reimbursement. Thank you.
Thank you, Serena. Excellent perspective. I think we're going to queue up now Rob Gillespie's talk that he recorded. He's at 35,000 feet right now.
Well, my name is Robert Gillespie. I'd like to thank the San Diego Shoulder Institute and the organizers for having me as part of this webinar, where we're discussing the ABCs and the 5 Ps of total shoulder replacement in the ambulatory surgery center. So I've been tasked with debating one of my good friends, Serena, on the outpatient shoulder replacement in the hospital setting. So this is something that we've been doing for a really long time. So without further ado, I do have some disclosures. They're all on the Academy website. So just for a brief outline, we're going to talk about the history of outpatient shoulder replacement, a little bit that's already been covered, why we had the initial move to doing outpatient shoulder replacement, what we did to optimize it, and why do we keep doing it. And I'm going to be competing against this good-looking guy who clearly probably already has made the arguments for why we should be doing this at the ambulatory surgery center. And I'm going to try to make some arguments for why we do it in the hospital setting, which I think is critical for a lot of reasons that I hope to tell you guys about during this talk. So we all know that shoulder arthroplasty is on the rise. I think that's one of the biggest things. Shoulder replacement is rising at rates that are much higher than total knee and total hip replacement. So we need the place to do them. We need an efficient way to do them. We need a cost-effective way to get the best patient outcomes. And I think that's critical. So as we see this rise, we need to get better at the process that goes on in order to have our patients get the best outcome. And we know from Quinn and from a lot of others that we've been able to negotiate very safely, figuring out a way to do outpatient shoulder replacement. It really gained some steam. Quinn and Ty down in Tennessee really showed us that this was something that was very doable. When we were first into practice, everyone stayed. And when I was a resident, people would stay a couple of days for their shoulder replacement. They'd have drains. They'd have all these things. And now we've progressed very quickly to these kind of things. And a lot of the modalities we'll talk about have allowed us to do that. And we've even gotten to the point you can see here, the Duke group has talked to us actually having outpatient revision shoulder replacements, which can be an interesting thing as well that we can talk a little bit about. So when we're thinking about some of this stuff, some of this is driven a little bit by the government. There has been a shift for the total shoulder replacements to be more an outpatient bill. It's come off the inpatient only list, I believe, in about 2021. And you can see here, if you do an inpatient shoulder replacement in a hospital setting, you can make a slightly more money, but it's a lot bigger hill to climb to get that reimbursement. And as you can see here, they've decreased the reimbursement for outpatient shoulder replacement. So we have to figure out ways of doing it efficiently, cost effective, and again, good for the patients. So when did we start doing this? Well, in 2017, we started looking at this. Our total joints colleagues at our university hospitals in Cleveland started doing outpatient knee and hip replacement. So we started doing this. We had initial criteria. We really followed what Quinn had, less than 75. They had to have some home assistance, and it had to be a primary, as well as the medical comorbidities had to be fairly low. Our readmission rate was really good, less than 1%. They got antibiotics and saw a PT occupational therapist before they went home, and we were amazed at how well they did. And a lot of this was based on the fact that when we used to round on our patients on post-op day one, they'd just be sitting there eating their breakfast, drinking coffee, and having no problems. So why wouldn't we send them home? And Quinn's studies and other studies have really been very consistent. We've been able to reproduce that. And then COVID happened, and then everything changed in my world, because it went from having fairly strict criteria for our patients to go home the same day of surgery from our hospital to now almost everyone went home. We had 93-year-olds that were going home. We would talk to them about with their family and other things. And so it really opened our eyes maybe one benefit of COVID was it opened our eyes to the fact that maybe we could really broaden our indications for our patients to go home on. An advantage in the hospital was that if, God forbid, you needed to stay, then you had a place to stay that would be well equipped for getting your disposition correct. So Medicare reimbursement also sort of played a role in this. In 2021, it came off the IPO list. And so again, we had to start thinking more and more about how to consolidate those costs. There was an incentive to move it to the outpatient ambulatory center. Even if it was within the hospitals wanted us to do that, find an efficient way of not admitting the patients, not taking up beds in the hospital, and not increasing our risk and exposing our patients to possible infections and nosocomial infections that they would get by being in the hospital. So then what was our current algorithm? Again, we do this all in the hospital setting. We do not go to the ambulatory surgery center. These are all in 300 to 400 bed hospitals that we're doing our outpatient shoulder replacement. So my inclusion is really any patient that needs a total shoulder. And my only absolute contraindications for people who are going to go home the same day are those that need to use their arm to weight bear. Very rarely we have a social support issue where they don't have family that can help them for the first day or so. And age really is no longer a factor. So I could see anybody's grandmother, and if they're cleared, medically optimized by their primary care doc and by our PATs, there's no reason why they can't go home. They could have a cardiac history, pulmonary history, and that's really one of the big takeaway points. So why not in the hospital? Why wouldn't you do this? Well, this is from our good friend Larry Galata, who talks about complications of shoulder replacement. And this video is a really fun video that he showed. And, you know, why, if you're not in the hospital and you get into one of these complications that we can in the shoulder replacement, because we're very close to the vessels, you know, this is something that I would say, even though it happens very, very, very rarely, this is another reason that you should think about doing outpatient shoulder replacement in a hospital setting. You'll have vascular surgery potentially available. You have other resources available, blood products, things like that. Probably even have better anesthesiologists that can help you if you run into complications. So that's our number one big reason why we continue to do our outpatient shoulder replacement in the hospital setting. I think there's also something to be said for patient comfort and satisfaction. I have a lot of older patients. They seem to think that coming to a hospital is going to be a better thing, even if they go home the same day. And if things go bad, whether it's anesthesia, nausea, or they don't clear PT or OT, there's somewhere for them to stay that's equipped for that. It's not just they're not just staying behind a curtain at an ambulatory surgery center. They are actually in a hospital being cared for by registered nurses who know how to take care of them and then get them going home the next day, or God forbid, if they need a skilled nursing facility. So what's our current regimen, and how do we get a lot of these patients to get home? Well, it's very similar to other people do. We do a general anesthesia with a single shot block. We have a really low cost of implants and trays. Again, our direct costs and our indirect costs are playing a large role in what we're trying to do with outpatient shoulder replacement. It's good for the patient for sure, but then also the hospitals are going to need to be able to make it a meaningful surgery. So we've really worked on vendor consolidation and tray consolidation. Every single one of our patients gets PT, OT on the day of surgery, either before or after, depending on the time of day they're having their surgery. We have a multimodal pain medication regimen. We love Toradol if their kidneys are good. We try to stay away from the narcotics, but again, we do have narcotics at breakthrough. I do think cold therapy is critical. The only calls I ever get from my patients who go home the same day of surgery are those who did not get cold therapy. We do 1 week of oral antibiotics after a single dose of IV antibiotics. We used to give them an extra dose of IV antibiotics, and that just didn't seem to be cost effective or make sense. And so we have switched to that. And we do give them one dose of tranexamic acid preoperatively. Our hospital very nicely showed years ago that tranexamic acid was very effective at decreasing hematomas and blood loss after total shoulder replacement. And so we still believe in that today. So what's next here? Well, we want to continue to work on decreasing direct costs in the hospital setting. If you look at the hospital setting versus the ambulatory surgery center, you can't just take the actual reimbursement, which you get in a hospital setting for an outpatient surgery and translate to an ambulatory surgery center. That those are going to be, in theory, we can be more cost effective in the ambulatory surgery center, but that can be a very much of a loss leader. So in the hospital setting, we know what our reimbursement is going to be for the outpatient shoulder replacement. So we're going to continue to work on trade consolidation, vendor consolidation, disposable timeouts. We're going to partner with the hospital to optimize those indirect costs, those things that we don't really have a direct effect on. And we're going to explore opportunities that enhance patient experience, but do not compromise our patient outcomes. And that's critical. So in summary, I would say the outpatient total shoulder replacement is safe and effective. Quinn and everyone on this call has shown that very clearly. Programs can be set up in an ASC or a hospital setting. I think either are great. I do prefer the hospital setting, and you'll see why here in a second. Hospital setting may allow for a more aggressive algorithm patient selection. I don't have to think about whether my patients are going to go home or not. I tell them that they're all going to go home. And if they can't go home, we're already in that setting, which would be well equipped to deal with that. So there's no decision on whether this patient's going to get their surgery in ASC or this patient's going to get their surgery in the hospital. They're all going to get their surgery at the same two hospitals that I operate at, and we don't have to think about it. It makes it much easier for my team. It makes it much easier for anesthesia. I do believe that the hospital setting is better at handling the very rare but catastrophic complications that we talked about. And I do think this is just, again, easier for our team to schedule. Everyone goes home. 90% of our patients go home, but if you don't go home, we have a place for you, and it's much more better equipped than a small ambulatory surgery center to take care of you for that 23 to 72 hours that you may require after surgery. I'd like to thank the San Diego Shoulder Institute again for giving me the opportunity to be a part of this webinar, and I'm looking forward to hearing more about the questions and answers in a little bit. Thank you again.
Excellent work, guys. We have some time for questions. We don't have any in the Q&A box, so anybody online, please put them in there if you have any. I'd be remiss if we didn't thank our sponsors, Smith Nephew, Innovus, and Depew Synthes. We sincerely appreciate the support in putting on this sort of educational activity, and you guys have been great partners for us. Let's start at the top. Chris, you talked about program and pathways. What was your number one administrative hurdle to building a program for outpatient arthroplasty?
I think it was buy-in. Until we looked at our own data, they weren't willing to invest the money that we needed to make this successful. And then once we showed how we could improve our outcomes and be cost conscious to the healthcare system, they really doubled down and helped us. And then once we had that and they saw how much money they were making and saving by our good outcomes, it just kind of exploded. So there was that hurdle that is always financial that we had to overcome.
Fair enough. And Ron, you talked about pain control. You guys have done some great work on that. I've noticed in the papers and when we talk at meetings and such, it gets a little bit religious in that everybody has their own cocktail, and that's that darn it, that's what I do. Can you take us through what has worked for you for folks on the call that may want to jot some of that down?
Sure. Interscaling block certainly by the anesthesiologist or the anesthesia team in the pre-op holding area. And most of the patients do get Toradol at the time of surgery, so that also helps them. In the post-op period, we do a Tylenol dosing that's scheduled, as well as a anti-inflammatory. It seems like in our system, meloxicam is like the Kaiser vitamin, so it's a Celebrex light type thing. So Kaiser must have a great contract on. It's cheap. We then move into a gabapentin single 300 a morning, as well as a steroid, just the 3-2-1, a very light sliding scale of that. There are some GI meds, and then the narcotic is usually dosed, and it's there are multiple choices, but all of them are capped at like either 20 or 30 pills. So people don't get a lot of narcotic, and we've really walked away from refilling the narcotics. And I do a little bit of time to speak to the patients preoperatively about the fact that it's very rare that I refill the narcotic. They have to that's that kind of pain, surgery hurts type of discussion, that they need to know that they're going to have to kind of get ready for a little bit of achiness. And patients by and large don't need refills. It's just amazing. And so it really pushes me to want to do narcotic-free regimens. I haven't done that. I hope that's enough detail you wanted.
Yeah, that's excellent. We got a question in the chat of, do you have the patient pick up the pain meds prior to surgery?
Yeah, I do. I tell them, pick them up the day before. I tell them, if you eat these before and say, oh, guess what? I ate them all. I need more. I'm not going to give them to you.
Got it.
I'm not impressed because I don't need to impress anybody. There's a lot of people coming through. And so I just give them the clean deal.
Grant, I've long been a fan of the calculator that you guys have put together for patient selection. Do you ever find yourself needing to whip that out in clinic and like explain to a patient like why they may be better in an outpatient setting versus an inpatient setting? Or how do you employ that in your practice?
You know, thanks, Quinn. So first of all, you know, the Duke team gets a lot of credit for that, but it's been an honor to be a part of it. I think the key is a couple things. One is, you know, when you're kind of starting to look at outpatient appropriateness or 90-day readmission rates, et cetera, it's helpful. But then as you kind of get used to it, you just kind of have that doorway diagnosis like Gestalt. That's sort of number one. Number two is the conversation for outpatient totally changed in 2020 with COVID. You know, it used to be, oh no, my Medicare, my insurance pays for me to be inpatient. And so I want to be waited on hand and foot in a hospital. And I don't want to do things on my own. I want to be in a hospital. And then as soon as COVID hit and people were afraid to go to that setting, people were begging for outpatient. So it really is not a hard sell, so to speak, now. And I think that, as often is, the hip and knee folks have kind of paved the way. You know, so many of these have been done outpatient. Say, oh, yeah, I had my hip and knee there. Well, this is even easier. You don't walk in your hands, so let's do it. So I think I would say the calculators are very helpful. I use them, but I use them less and less because it's just not necessary at this point.
Gotcha.
Gwen, so I have a question for this about how outpatient is your outpatient? Meaning, is this an OR that is attached to your office that is very far from any hospital, or is this just an outpatient case being done at the hospital that you're sending home the same day? Because I think that these are very different circumstances, right? Because you could have a very effective outpatient program, but if it's being done and you have the full hospital system involved in navigating with nurses and doing all these different things, that's very different than being in private practice and working at a surgery center where you are the system that you have to create, right? So, Grant, is your outpatient stuff done at a surgery center that is right across the street from a hospital or in the hospital? How do you do it?
Yeah. So to answer that, it's a freestanding ASC that I'm working at. One of them is in downtown Chicago, so Northwestern ER would be, like a block away, right? And one of them is, but it's not attached to it. It's in a totally separate building. One of them is in a more suburban location where a different, level 4 hospital is like a mile away. So they're not attached to hospitals. They're freestanding ASCs. I think the second thing to point out is the data that Chris Clifto and I both alluded to about the study looking at who can go outpatient. That was done in an inpatient setting, and then we looked at who was able to leave the next morning. So it's important to note that we then extrapolated, hey, the people that had their surgery and left within 24 hours are probably the people that would be most able to do outpatient surgery. But that study was done study was done before this was approved. So that was the only way to look at it.
I don't know whether to be inspired or embarrassed by your Excel sheet because I don't have your level of grit to do that. And so for those of us who just cannot bring ourselves to sit down and do what you do, do you have any advice on vendors? Have you guys investigated any of these programs like Patient IQ or Obaird? And do you have a recommendation or thoughts on them?
Yeah, so first off, Quinn, I'm sure you got way more grit than I do. I think that's a great question, and there's a bunch of different ways to do this. So certainly, we've investigated Patient IQ. They do a great job. hats off to Macatellis and their team. There's some benefits that you get with them. Aubert, I think, also provides a really great product, and we've investigated them as well. There are substantial costs with both of them. If you're looking for a lower cost thing, many institutions have access to RedCap, and RedCap actually can do this for you. It takes some setup, and part of the reason we particularly didn't want to use RedCap is I don't, I don't love the amount of setup and the time, like how tied you are to that one particular product. And then the other reason why, and this I think is probably the direction in which most people are going, is if you have Epic, all of your patients have MyChart to access their EMR. And I'm sure even for people who aren't using Epic, if there's a patient portal, your patient has access to the records because patients use them all the time for renewing their medications and making appointments and accessing their routes and accessing their labs. So like my patients all have access to MyChart. So the direction we're moving right now is to have Epic collect this for us because we can get better. Like the patients log in, they say, oh, I have a survey to complete. They complete their survey while they're doing something else anyway. They already recognize like that email that comes from MyChart. And if it just says you have a new survey, they log in anyway. So that I think ultimately is what's like ultimately once Epic completely gets their act together, they're going to eat everyone else's lunch because they have that home ground advantage. So we're moving that direction at my institution. It's been a challenge because at least our instance of Epic did not have ASCS built in. So we have to like custom build that. So like these are the kind of clunky things that I think Epic's going to figure out in the long run. But I think if you were to make the long-term bet, that's the bet to make. If you want the cheapest bet, I would go with RedCap. And then I think if you're looking for someone who's all in, where you're willing to spend a little more money, then Aubert and PatientIQ are really great providers.
Excellent. Ron?
Riff on this, just ask Peter and the rest of the team. Well, when Peter said he was making he has his own personal list. I just started on my phone working with Claude, Anthropic, Claude, and I was seeing if Claude Cowork could create an agent to do all this work. They'd phone call the patients and do everything. And it was really interesting to see, like, the big issues are the HIPAA and plug back into the EMR of choice, whichever your company is with or whatever your private practice is with. But I think in the future, I believe the costs will go down because there'll be an artificial person calling and either emailing or texting or talking to the person as a hologram. What do you guys think about that? Like just to move this forward?
And I look, I can't wait for that future. My understanding is that currently it's not legal for you to share any protected health information through any of the currently available AI solutions. I think there will be solutions in the future that allow that, but even within like we have, for instance, like an EDU version of ChatGPT that's like behind the firewall here at the U, and even that we're really not supposed to share PHI with. So I'm excited for that future. I don't think that exists currently.
Okay, I think a frequent question we all get is about cost control and implant control, because as you pointed out, that's responsible for so much of the cost. There's several methods to try to contain implant costs. How have you gone about it at Duke?
Yeah, that's a good question, and it is the most important thing. I think at Duke, we moved to a sort of tiered vendor system based upon what the physicians were currently using, and then negotiated with the companies. Initially, it was supposed to be a two-tiered system, so we picked two systems we liked, and then we expanded to three systems. And then based on that, we were able to negotiate significant savings. I think we ended up saving the institution over $2 million in the span of about 2 years. But we were also somewhat incentivized in a unique way because we were sort of gaining in the savings. 25% of that came back to our section to be used for academic purposes, obviously. So that worked very effectively. It was a 3-year contract. So, you know, you lower your costs, and then your contract runs out. And, you know, the problem is you get to a point where you just can't lower it anymore. And if you really want to continue to get the savings and whatever you're going to do with the savings, you have to then find other vendors. So it's not a foolproof system, but in general, I think consolidation is key. I think shared alignment amongst providers is key. And that's usually a bit harder when you get into these academic centers where there are all kinds of relationships. But that is usually the biggest way I know to sort of manage costs from implants.
I had a very sarcastic response lined up for your $2 million savings, and then you said you were smart enough to do gain sharing. So that's really well done.
Done on that. I wanted to ask another question about staying along the same theme of how outpatient is your outpatient, right? Chris, for your patients that are having outpatient shoulder arthroplasty, are they being done in a place where they have to go home the same day? Because these freestanding surgery centers, not every state allows for a 23-hour sleeping bed for these patients.
We have two models and pathways. I guess we have three. One is just a straight inpatient. We have a second bedded outpatient pathway where and these are like our tweener patients who are able to stay if they have to, but the plan is for them to go home. And then we have our straight ASC pathway. And we work with our preoperative colleagues to help us decide which patient fits in that pathway.
Serena in Philly, are you locked in? If you take the patient to the freestanding center, do those patients have to go home the same day, or do you have a overnight opportunity there if you needed it?
Yeah, so at all of our ASCs that perform outpatient total shoulders and hips and knees, so all of the ASCs that are kind of what I would call standalone ASCs, they're for the most part affiliated or right across the street from a hospital. And so the patient, if there's an issue, can get moved across the street. Our specialty hospital, they can stay overnight. And then some of our ASCs do have a 23-hour allowance. So it's variable.
I think it's important to know, though, is that I believe most states have laws where you have to have a transfer agreement with a hospital from an ASC if it's a freestanding facility. So any physicians that are on the webinar tonight that are doing this and are early in their freestanding ASC experience, or they're building one, that's an important component of what you need to have.
Yeah, but that's also hard because at least at our institution, we have to call EMS and it's right across the street. So it's a huge cost and such a detractor for our healthcare system when that happens. So
It's bad optics,
yeah,
right? I mean,
yeah, it's like the patient can't breathe from a block and we're putting them in the ambulance. So
right. Well,
Mine's ASC is like 5 miles down the 405 without anything. So in California, everything is so fraudulent and disrupted that it's hard to even get an ambulance. So that picture of Larry Gulata's bleeding was really freaking me out, you know.
It's pretty traumatic to see that. I hope it was a staged event that and you got to give Larry credit for his acting. Yeah, our outpatient surgery center is not anywhere near a hospital, and it does not have 23-hour capacity. So the patients that we take there are patients that, they're going home on the same day. And so we have to be very selective.
Lorena, let's finish up with you. You really outlined very nicely how the incentives line up for all the players in private practice. What would you say right now is your biggest pain point when it comes to outpatient shoulder arthroplasty, regardless of the setting that you're doing it in?
To be honest, I don't think we have huge problems with getting patients through the process. I think that was an issue maybe 3 to 5 years ago, and all the work that's been done by everybody on this call around the country and all the messaging that's been done with patients and the hospital system has really helped to solve those problems. I think the biggest thing that we have seen is we are doing less and less shoulder replacement at the hospital, and we're doing less as a practice. We're doing less and less hip and knee replacement at the hospital, and we're doing less and less spine surgery at the hospital. And so those hospitals have OR availability, and they want to fill those ORs. And so it does lead to some tension between our practice and the hospital in terms of, do they need to hire their own orthopedic surgeons to bring more cases into their facilities that are in some ways losing volume. And so I think that's the biggest struggle that we have, and how do we manage that relationship?
I think that's a good point. I mean, you and I have pretty similar practice environments, and I think OK touched on this a little bit too. When you have a fully physician-owned ASC, you're responsible for the insurance contracts, and that is our setup, and that is our biggest headache, is fighting with a very diverse set of insurers here in our region, trying to get all the contracts in line and knowing who's approved and who's not. Well, I think we've hit everybody. Howard, do you have any more questions? I don't have any more in the chat box.
My biggest pain point is the social component of this. You may have an ideal patient that's perfect for outpatient, and then you haven't really done a good enough job digging into their social circumstances and find out, relatively, late that I forget who said that basically having a man at home is essentially the same as having nothing at home. That was you, Grant, right? Yeah. So I think the social component of it is one of my biggest pain points. And great job, everyone. This is a beautiful educational experience for me.
Can I just ask a question? A very simple question. For those of you who have your guidelines, is there an age at which you will say, I cannot do your surgery as an outpatient? You need to stay at least 23 hours. Is there any age? Is it 90? Is it 85? Or can they go home if they're a 90-year-old having a total shoulder? Because I'll say for me personally, I feel a little weird as patients get into the 75 to 80 range. I worry about them falling. I get a little nervous about sending them home the same day. But I'm just curious if I'm just being a little bit, too cautious.
I think the oldest I've done outpatient is 91.
Okay.
That sounds ridiculous, but I'm a huge believer that patients vary dramatically. I mean, you've all seen the 56-year-old that looks 85 and the 87-year-old that looks 56. And I personally just don't think that a specific number is necessarily something that makes sense for patients, but I could be wrong.
In Memphis, if you're 90 and ready for a shoulder replacement, you have been naturally selected, where I'm not going to be able to do anything worse to you than your environment hasn't already done.
I always tell patients too, what's sleeping overnight going to do for you that a nurse never visits you once the whole night? You're going to go home the next day anyway, so go home today.
Yeah, with pain no longer being the main reason that people are in the hospital for this, and we have elderly folks, if they're peeing and walking and eating and giving the nurses hell and feeling fine, there really is no reason for them to be there. So we set it up as the expectation is that they're going home the same day, and you can tell immediately who's going to spend the night, because when you say that and they go, "Oh, no." They're spending the night because they have their own personal expectation.
All right, guys. Well, that was a fantastic session. Really appreciate everybody's contributions. Again, thank you to our sponsors, and thank you for everybody online for attending, and hope you all have a great night.
Thank you.
Thanks, everybody.
Thanks, guys. Great seeing everybody.
Thank you.
Are you